Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS Quality Program Consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hello, Dr. Mingle.
Good afternoon, Hadley, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we start, I want to remind our listeners that they can leave their questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. I'd like to begin with a question about primary care first. In preparation for that, Dr. Mingle, can you remind us what primary care first is?
Primary care first is one of the newest additions to the experimental alternative payment models in operation under the Center for Medicare and Medicaid Innovation, the CMMI. PCF, that is Primary Care First, replaces the Comprehensive Primary Care CPC Plus program that ran from January 1st, 2017 through December 31st, 2021. Lessons learned from the CPC Plus program were integrated into the new PCF program, and CPC Plus participating practices were encouraged to roll over into the PCF program. There are about 2,600 practices participating in two cohorts. The first cohort started January 1st of 2021. The second cohort started just a year later, January 1st of 2022. The program is scheduled to end after the 2026 performance year. Practices are sorted into 4 strata by the average complexity score of the attributed patient panel, as indicated by the average patient hierarchical condition category scores. That's the HCC scores. Payment for primary care first participants is a combination of a prospective quarterly professional population-based payment, which is a care management fee tiered to the risk strata of the practice. Then there's a flat visit fee for every primary care visit paid based on the claim submitted. And then there's a performance-based adjustment paid quarterly. Factoring into that quarterly performance-based adjustment are first a total per capita cost measure calculated by Medicare from claims. That's the TPCC measure we've been using for years. There's also an acute hospital utilization measure calculated by Medicare from claims. Medicare uses either one of those depending on the risk tier of the practice. And then there's a set of quality measures, also specific to the risk tier. As with all alternative payment models under the CMMI, there is a quality measure requirement. The specific measures vary by the complexity strata, as measured by that average HCC risk score of the patient panel. For practices in the lower 2 risk strata, that is levels 1 and 2, it's measure 1, we know well as hemoglobin A1C, measure 236, we know as a controlling high blood pressure measure, measure 113, which is the colorectal cancer screening measure, and advanced care plan. And more about that later. It's not the measure 47 that you were used to from the MIPS menu of measures. And there's also a CAPS survey with a few amendments added specific to primary care first. Measures for the 2 higher risk strata, levels 3 and 4, are for advanced care plan, the same one as before, the CAP survey as likewise. There has been a days at home measure that was used in the first 2 years of the program, but it's on hold now for the 2023 performance year, may or may not be reintroduced at a later date. That should be a nice introduction to the Primary Care First program and prepare us for the other question.
And thank you for that explanation. That's definitely a complex program. To continue with that thought, Miranda would like to know, we are participating in Medicare's Primary Care First program. We submitted our quality measures for 2022 as ECQMs, but our quality submission was disqualified. Why did that happen? And what can we do about it?
Great question, Miranda. And not knowing the specifics of your situation, there are several things that can go wrong with your quality submission. Working backwards from a winning score, the first potential problem is score. For primary care first, quality measures have a pass-fail dynamic. You have to have a score that meets or exceeds the 30th percentile nationwide on each of your quality measures to earn any of your quarterly performance-based adjustment. Medicare publishes annually, early in the performance year, the goal benchmark minimum performance rate for each measure. If you don't achieve at least that 30th percentile benchmark for each of your measures, you do not collect any of the performance-based adjustment. The second potential problem is timeliness of the submission. For the hemoglobin A1C, blood pressure control, and colorectal cancer screening measures that apply to risk strata 1 and 2, those measures have to be submitted to Medicare before the close of the annual submission window, which is typically at the end of the day on March 31st. The third problem is mechanism. Primary Care First is one of the few programs that limits choice. Each measure has to be submitted using the proper mechanism by the March 31st due date. In most programs, hemoglobin A1C, blood pressure, colorectal cancer screening can be submitted by ECQMs, by MIPS CQMs, or by claims. For Primary Care First, the hemoglobin A1C, blood pressure control, and colorectal cancer screening measures have to be submitted as ECQMs. Advanced Care Plan is calculated by Medicare from your Part B claims as an administrative claims measure, and that's the only way it's accepted. The fourth potential problem is EHR documentation workflows. For the ECQM measures, you need to have entered data for each patient in the right place to be picked up by the EHR's ECQMs. You might have performed the care, you might have recorded in the chart, but if the record is not visible exactly how and where the ECQM tool is looking for it, you may fail to achieve a winning benchmark. The fifth potential problem is advanced care planning documentation workflows. Probably the greatest risk for failing the quality measurement component is the advanced care plan administrative claims measure. Medicare is going to look in your claims for CPT billing codes 99497 or 99498 that indicated you charged for a visit in which you discussed an advanced care plan. They also look for CPT2 code, that is the QDC codes 1123F or 1124F, indicating that it was done previously or you did it in this visit in a context that you could not or did not bill specifically for it. You might have done it, it might be clearly recorded in a chart, but if it's not reflected in a claim with one of these service codes attached to a visit in the applicable performance year, it will not be credited to you. Now, if you failed and you're destined not to collect a performance-based adjustment this year, there are a couple things you can do. One that you should and one and will help you, and one that may or may not. First, fix whatever it was that failed you in the first year. Make sure your data is recorded in the right place for the EHR to pick it up for the ECQM measure. That's hemoglobin A1C, blood pressure, and colorectal cancer screening. You must put it in the right place in all of your visits going forward. You can also amend prior visits to transcribe the data you collected previously and recorded in the wrong way, put it in the right place to be picked up. Now, if you have not been adding an advanced care plan CPT or QDC code to your Medicare claims, you only have to do it once in a year for each of your eligible patients. Eligible patients are Medicare patients 65 or over. This is an exception to the usual all insurers, all patients strategy for other quality measures. So if you're going to see most of your patients still in the rest of the year, you may be able to correct this without any loss going forward. If you see them again, you can put the QDC code or the CPT code on it. You are not permitted to amend a previous claim with a QDC code. That is the 1123F or the 1124F. But if you missed an opportunity to bill for the advanced care plan discussion, you can submit an amended claim, including that code. Second, this may or may not work, you can request a targeted review by Medicare. To request a targeted review, you need to log in to the qpp.cms.gov website using your HARP credentials and choose Targeted Review from the menu on the left. You'll see a list of permissible reasons for review and a list of impermissible reasons in the application form. If your request is not permitted, you can enter a ticket to request help from the QPP help desk. So good luck. I hope you can correct things for next year and get qualified for your performance bonus.
Great. Thank you, Dr. Mingle. Our next question today is from June. June would like to know, we are thinking about participating in MIPS Value Pathways for 2023. How do I know which population health measure to choose? Should I choose one that we won't have eligibility for so it gets reweighted?
Interesting thought, June. Unfortunately, it won't work that way. When you participate in an MVP, that is a MIPS Value Pathway, you have to choose one of two population health measures. The same two population health measures are options available to each of the MVPs. One of them is Measure 479, the hospital-wide 30-day all-cause unplanned readmission rate. The second one is Measure 484, the risk standardized hospital admission rates for patients with multiple chronic conditions. Both of these measures are administrative claims measures, which means Medicare calculates results from claims submitted for care. For now, though it might change in the future, Medicare always calculates administrative claims measures at the tax ID specific whole practice level. They will not be calculated at the subgroup level. Choose whichever measure. If you meet case minimums, the measure will be calculated. If you don't meet case minimums, Medicare will attempt to calculate the other measure you did not select and give you credit for that one. If one or both are measurable, that score will be integrated into your quality score. If you don't meet case minimum on either measure, the population health selection will not factor into your quality score. You won't have population health achievement points in your quality numerator, and the 10 potential achievement points for population health will not be reflected in the quality denominator.
Excellent. Thank you, Dr. Mingle, for that explanation.
Thank you, Hadley, and thank you, everyone, for all the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.